Welcome everyone to this patient-focused webinar. My name is Sydney Stevens from Insight Tech, and I'm pleased to be a part of today's virtual educational event. Please be patient as we take a few more moments to allow everyone to get signed on, and the presentation will begin shortly. Welcome everyone to this patient-focused webinar. My name is Sydney Stevens from Insight Tech, and I'm pleased to be a part of today's virtual educational event. Please be patient as we take a few more moments to allow everyone to get signed on, and the presentation will begin shortly. Okay, it looks like we have a great number of attendees signed on, so let's go ahead and begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from both Dr. Langevin and Dr. Diaz as they discussed focused ultrasound as a treatment option for patients diagnosed with essential tremor or tremor-dominant Parkinson's disease. As questions arise during the presentation, please utilize that Q&A button that is located at the bottom of your screen, and we will have time after the presentation to answer the questions that are asked within the chat. Now let me begin by introducing you to today's presenters. Dr. Langevin is a board-certified and fellowship-trained neurosurgeon specializing in the surgical treatments of movement disorders, epilepsy, and psychiatric conditions. He was selected as the 2016 Super Doctor Rising Star and achieved the Super Doctor designation again in 2017. He has extensive experience in neuromodulations to treat conditions such as Parkinson's disease, essential tremor, dystonia, epilepsy, and obsessive-compulsive disorder. He is a director of the Restorative Neurosurgery and Deep Brain Stimulation programs at the Pacific Movement Disorder Center, located at Providence St. John Health Center and Providence Little Company of Mary Medical Center. Now, Dr. Diaz. Dr. Diaz is a board-certified neurologist and with fellowship training specializing in movement disorders. She also has specialized training in the evaluation and programming of deep brain stimulation as a treatment for Parkinson's disease, essential tremor, and dystonia, as well as therapeutic administration of Botox injections for non-cosmetic indications such as focal dystonia and limb plasticity. Her research focuses on industry-sponsored clinical trials in Parkinson's disease and other collaborative clinical projects in the field of neurodegenerative disorders. I want to welcome you, Dr. Diaz and Dr. Langevin, for presenting this afternoon, and thank you so much for being here. I want to remind everyone to please utilize that Q&A button that is located at the bottom of your screen, and we will make sure to get all of those questions asked that are within the chat. So Dr. Diaz and Dr. Langevin, again, thank you so much, and the floor is now all yours.
Thank you so much, Sydney, and welcome everybody. Good evening to this session, this webinar on MRI-guided focused ultrasound. As Sydney mentioned, this is going to be a
Dr. Diaz, I think you were just muted on accident. If you go to the bottom of your screen, you should be able to.
There you go. Sorry, I had
no
one
worries.
of those sort of technical storms where my screen just went crazy. So I apologize. Welcome everybody. If you didn't hear me say that to today's webinar on MRI guided focused ultrasound. So you're going to hear two speakers today, as Sydney just mentioned. We're going to tag team this. I am a movement disorder neurologist, so I'm going to begin today's webinar talking a little bit about two of the most common movement disorders that we see in our practice, essential tremor and Parkinson's disease, go over their clinical diagnosis, what options we have from a medical treatment, and when do we start thinking about surgical options such as focused ultrasound and who's a good candidate. And then I'm going to hand it over to Dr. Langevin to discuss a little bit more about the technical aspects of the procedure, the efficacy of it, and at the end we'll have a Q&A session. So let's begin with essential tremor. So Essential tremor is actually considered the most or one of the most common movement disorders. The Essential Tremor Foundation estimates that there's about 10 million Americans living with ET in this country. It is generally a tremor disorder in most part, and it causes tremor in the hands, what we call the upper extremities, that occurs when the hands or the arms are in movement, when they're in doing activities such as eating, holding forks, holding a cup, writing, brushing your teeth, putting on makeup, dressing, what we call daily activities. So we need tremor in the hands to make this diagnosis. About 20 to 30% of people can also experience tremor in other body areas. For example, a head tremor, sometimes a no tremor or a yes tremor. And underneath this, sometimes people can also have a little bit of torticollis, a little bit of a head tilt or movement of the head. People can also get a facial tremor. They can sometimes get a voice tremor. Sometimes it only comes out when people are upset or emotional about something. Rarely, they can also have tremor in the legs, or sometimes when standing, say standing on somewhere, they get a little bit of bobbing of the legs. And this type of tremor tends to very characteristically, if somebody is stressed, if somebody's under anxiety, if somebody's drank too much caffeine, tends to get worse in the short term. And about 50% of people, if they drink a little glass of wine or have some alcohol, this tremor tends to get better. Um, we don't really quite understand what causes essential tremor at this point, but we do know that in about 50% of people, it can run in families or they have multiple family members with tremor. So sometimes that can be a key to diagnosis. It can be a very problematic tremor, as you can see in this video here. The severity of the tremor over the years can get worse. So the amplitude of the tremor can worsen as the years progress. For some people, this can start to impact their day significantly. So several studies, utilizing patient questionnaires have found that about 80% of people experience tremor that impacts at least one of their daily functions: eating, writing, bathing, grooming. And about 50% of people, it can impact their ability to do their job: writing, using a computer mouse, maybe tapping on the keyboard, or other professions that maybe really need very fine motor control where tremor can become a problem. About 45% of people report impact on their ability to do their hobbies and have to let go of them. Socially, more than 60% of people feel that they get embarrassed by the tremor and it affects their ability to socialize. And so many times people end up over the years withdrawing from family and social events. And this can lead to about depression in about 40% of people and anxiety in about 20% of people. And over the years, some people do start to require assistance from others to do even basic functions like dressing, eating, drinking, bathing. As I mentioned, we don't really know the exact cause of essential tremor. So because of this, we don't have specific tests. We don't quite understand what's happening in the nervous system. There's no distinct pathology that we've been really be able to put our thumb on, as classic for essential tremor. So we don't have any specific diagnostic tests. It's really just based mostly on history, medical history and examination. So again, we listen to how the tremor comes on, how the tremor progresses over the years. In an examination room, we'll have people kind of do things with their hands, put them in certain positions. We'll have people write, as you can see in our diagram here, where the tremor often comes out. We'll have people write their name or draw circles. We may even bring out a cup or a fork and spoon and have them try to mimic like they're doing these activities, and very often the tremor will come out. We also look for supportive factors, such as if there's a strong family history of tremor, or if the tremor improves with alcohol. As I mentioned, these can be indicators of essential tremor. One of the other things that we do is we make sure that we're not looking for, that we're not missing any other causes of tremor or things that can exacerbate somebody that normally just has a little bit of tremor. Things like People are drinking too much caffeine. And again, we talk about cups of coffee, we talk about other caffeinated drinks like sodas, Mountain Dew, too much dark chocolate, too much black tea, too much green tea, things that have, a lot of caffeine that people aren't drinking or eating too much of this. We look for other medical conditions. Liver, kidney, and thyroid dysfunction can sometimes aggravate tremor. We look to see that people are not on certain medications that can bring out tremor. People that are on chronic steroids for autoimmune or other diseases, people that are consistently taking certain types of asthma inhalers, people that are on amphetamines, either for wakefulness or for ADHD, and certain psychiatric medications can also bring out tremor for some people. And of course, if people are a certain age, Parkinson's disease can sometimes be confused with essential tremor. So once we've made that diagnosis, what options do we have for treatment? Well, always our first question is how intrusive is the tremor? Because there's a lot of people that live out there that have tremor, but yet are functioning perfectly okay. It's maybe a little bit bothersome, but the tremor doesn't get in their way, either at home or at work. And so we don't always treat the tremor. When it starts becoming intrusive, that's when we start thinking about medical therapy. And we have two medications that are considered first line. Propranolol is actually the only medication that's approved for essential tremor. It's a beta blocker. And most people think about beta blockers that are used these days through their cardiology offices, metoprolol, atenolol, timolol. These are usually more used for cardiac reasons and for blood pressure control. But these are not as good because they're very cardiac specific. Propranolol is an old beta blocker that is more general in the body and tends to work at the muscles, and so many times can be used to kind of dampen down tremor. It can be used as needed or it could be scheduled and can be very effective. A second line agent is primidone. Again, it's been around for decades, just like propranolol has. This one is generally started more at bedtime because it can be a little sedating for people, but also can be very effective for some people and slowly increased over time. And actually, there are studies that show that if we do the two of them together, if we start one first and it's not enough and we add the other one, they can be synergistic and sometimes have additive effects if given together. If people can't tolerate these medications or they're just not effective enough, some second line agents that we use are topiramate, the other name for it is Topamax, zonisamide, another name is Zonegran, and we sometimes also, especially if we need to work with a cardiologist and they need a beta blocker for cardiac reasons, we sometimes will combine these with metoprolol or atenolol. If medications are not enough, we also have some assistive devices that are available. We have weighted utensils and gloves that people can use. These are forks, knives, spoons, and cups that are heavy. And the heavier something is, it weighs down the tremor. And for some people, it can actually be helpful and help them eat a little bit better. There are also vibrating utensils, what we call liftware, that are tuned to a person's tremor frequency and help to sometimes counteract a bit their tremor. So some people find those helpful. There are adaptive tools, magnetic buttons, laceless shoes. There are softwares that people can add to their computers to help them better adapt to a mouse or a large keyboard so people aren't double tapping because of the tremor. Writing aids, like I mentioned, dictaphones. And then there are also wearable stimulators that are wrist worn. These are devices that are like a smartwatch. You wear it on your wrist and it stimulates some nerves in the wrist that help dampen down the tremor by locally stimulating these nerves and also feeding back to the brain to an area where actually we think is probably a generator of the tremor and helps to dampen down. And there's two devices that are available. Number one is Calitrio, that's been around for a few years. And this one gives temporary relief. So people wear it for about 40 minutes and get maybe about an hour and a half of relief. There's a new one that just got approved last year called Felix AI Wristband. Not currently available just yet, but it's approved and working its way. But again, these wearable stimulators are great if people have some tremor, and we're just meaning to reduce the tremor to a degree where they can, function a little bit more effectively. Unfortunately, if people have a lot of tremor, these tools are not as helpful. We also use our rehab specialists a lot, physical and occupational therapists. I find them to be wonderful for our patients. They help strengthen, they help with coordination, and our occupational therapists work with people to develop strategy to improve their daily tasks and also assess them for some of these adaptive tools that I mentioned. So the challenges that we have with essential tremor is, unfortunately, the medical therapy that we have, when the tremor starts to become really bothersome, is not as effective. And so, studies have shown, multiple studies have shown that the medications that we have currently available in people that have moderate to severe tremor maybe will reduce the tremor by about 50%. And there's about 50% of people that, despite trying these medications and at an adequate dose, still don't get enough relief from the medications. These medications as well can have bothersome side effects. So they can cause sedation, they can cause dizziness, they can cause cognitive slowing, sometimes can cause moodiness. And so, about 50% of people have difficulty tolerating these medications. We also have to be careful because some of these medications can interact with other frequently used medications. For example, primidone is one of those, and probably the major one of these. It induces liver enzymes. And so if people are on medications that are also metabolized by those same liver enzymes, they will render those medications less effective. So if people are on blood thinners, if they're on hormonal therapies, if people are on certain antibiotics, vitamin K, vitamin D, these medications and supplements may be rendered less effective if people are started or on primidone. So it's important to always make sure that your doctor is looking at these indications, at these interactions. And so what happens is, because of this effectiveness, because of this tolerance issue, there's many people that have moderate to severe tremor that just end up living with it and stop going to see their neurologists and their doctors. I'm going to shift gears real quick, and I'm going to talk now about Parkinson's disease. Now, Parkinson's disease is much less common than essential tremor. The Parkinson's Foundation estimates that there's about 1 million Americans living in this country. Yet, we see much more Parkinson's disease in our clinics than we do essential tremor. And that's because it tends to be a much more debilitating condition than essential tremor. Like essential tremor, we don't know the exact cause. We know some things that are happening in the brain, but what causes it, we don't know. It tends to have some familial predominance. So, only about 10 to 15% of people with Parkinson's have a family history of PD, as opposed to 50% in essential tremor. The classic symptoms of Parkinson's are more widespread than just tremor. People get slow movement, they get muscular stiffness, they get changes in their posture and their walking, with the very classic symptoms of loss of facial expression, changes in their posture. They're little small shuffled steps. They may freeze when they walk, and they don't have a lot of movement, swagger when they walk. They have difficulty getting up from chairs. Tremor is one of the classic symptoms of Parkinson's, but 75% of people experience tremor with Parkinson's, not everybody. And it tends to be mainly a tremor at rest, meaning somebody's just sitting and relaxed and they're having tremor. And when they go to do something, the tremor goes away. Having said that, there are some people that tremor can spill over into holding things and also doing things with their hands, more of what we call an action tremor. And in about 25% of people, that tremor can become prominent enough that it starts to become disruptive or bothersome socially. So again, with Parkinson's disease, the diagnosis of Parkinson's disease is still a clinical diagnosis. We take a good history, listen to the onset and the course of the symptoms, and we do an examination looking for some of those classic signs that I just mentioned. Occasionally, we find people that are in the gray area where we're not quite sure whether they have Parkinson's disease, and essential tremor and Parkinson's can be that kind of gray area. Some people with Parkinson's disease, what we call tremor dominant Parkinson's, can present early with tremor and have a lot of tremor that sometimes can be diagnosed first as essential tremor. And a number of years later, they start developing the other symptoms of Parkinson's. And we've missed sort of years of diagnosis. So over the last 10 years or so, we've developed some tools to help us diagnose and differentiate between these conditions. A DAT scan is a nuclear study. It's a brain scan that uses a short-lived radioactive isotope, and it tries to visualize a person's ability to make dopamine in the brain. And in Parkinson's, that ability is lessened, it's effective, whereas in essential tremor, it's completely normal. And so in 2011, the FDA approved a DAT scan for this exact reason, to differentiate people with tremor that have, whether they're essential tremor or they're Parkinson's. And if you see here, this is an example of a DAT scan. A normal scan, or somebody that has essential tremor, they would have this comma-shaped or lima bean-shaped bright areas in the deep part of the brain where people make dopamine. And in somebody who has Parkinson's disease, they start to lose the tail of that comma, and it starts to become more of a period. And we do this at our hospital, a Little Company of Mary, quite often to try to differentiate between these two conditions. And it's pretty sensitive, depending on the age of the program that they're using in the hospital. The sensitivity can be anywhere from 80 to 100%, and it's pretty specific in the sense that you have some form of Parkinson's if you have a positive scan. Something that's come about a little bit more recent is a SYN1 skin biopsy. So this was, it's not FDA approved, but it is a lab approved by the FDA. It's an in-office procedure where we take 3 small skin biopsies in the shoulder, the knee, and down at the ankle. And we do it in the office under local anesthetic with a little bit of lidocaine. And what we're looking for are abnormal proteins that collect in the nervous system in Parkinson's. And we know that we can find them under the skin. And they should be positive in somebody who has Parkinson's and negative in somebody that has essential tremor. And the sensitivity of this is actually quite good. If it's positive, it's 95% sensitive that you have Parkinson's. I'm sorry, 99% specific. So these are 2 options if we have somebody with significant tremor, and there's a question as to whether we're dealing with Parkinson's disease or essential tremor. Now, the therapy for Parkinson's disease, we have a lot of choices these days. And I won't go too detailed into it because that could be a lecture all in itself. Our mainstay for treatment of Parkinson's are medications that try to boost or act like dopamine because, Parkinson's is a dopamine deficiency state in the brain. And we have the classic medication called Sinemet. And this is the one that's the gold standard that's been around for 60 years. We have synthetic forms of dopamine that called dopamine agonists. We have medications that help boost our Sinemet if it starts to wear off between doses or its effect starts to lessen. We have medications that maybe are a little bit better for tremor, anticholinergics, and amantadine, but these also can be racked with a lot of potential side effects: sedation, cognitive fog, dry mouth, urinary retention. So depending on the symptoms that the patients have, we may pick and choose which of these medications we're going to use. Like in essential tremor, we also use a lot of our allied health professionals, physical therapists, and occupational therapists. They can be very instrumental in helping people improve strength, improve coordination. Occupational therapists also to help people improve their daily tasks and what assistive devices may be appropriate for them. So very often for both these conditions, I will give people a referral for physical and occupational therapy. Unfortunately, what happens with Parkinson's over the years, especially once they start dopamine-based therapy, is as they start losing their own ability to make dopamine efficiently, they're more sort of reliant on the medications that we have that are trying to supply dopamine. And of course, those medications are taken up, they're used by the brain, and then they're metabolized. So the window of efficacy of these medications starts getting shorter and shorter, and people start taking medication more frequently. And of course, the brain starts to become more sensitive to these medications. And so people start developing the dancing like movements of Parkinson's, what we call dyskinesias. And the majority of people with Parkinson's, 5, 10, or longer years, can have some degree of this over the years. So this is what we call the motor complications of medical therapy in Parkinson's disease. So as a neurologist, when I'm seeing these patients in clinic, when do I start considering whether one of our available surgical options may be appropriate for my patient? When do I think about referring them? Well, again, I like to be fairly confident that the diagnosis that I've given my patients is that of essential tremor or Parkinson's disease. Unfortunately, I do see some misdiagnosis when people come to me. And so people should be seeing a neurologist or a movement disorder specialist and making sure that this diagnosis is correct. We usually like to give people a few years with this diagnosis, at least 4 or 5 years, just to flesh out that there aren't any other things that sometimes can look like these conditions in the beginning, but over the years may change. And so we want to be confident about our diagnosis. If somebody has tremor that is bothersome and is refractory to medications, whether it's essentially or Parkinson's disease, and they've tried 2 or more medications and either they can't tolerate them or they're getting inadequate benefit for their tremor, they may be a surgical candidate. If they have advanced Parkinson's symptoms, they have bothersome tremor, they have stiffness, and they may have progressed into this stage of motor complications, and they're getting disability, and these complications are intrusive, they may also be a candidate for surgical therapies. We have 2 surgical options that are available, and I usually end up talking to my patients about both. There's deep brain stimulation, which is a surgery. It's been around and approved now for over 20 years, and it involves implantation of electrodes and a pacemaker-like device under the chest that fuels it. And it stimulates certain deep targets in the brain that help treat tremor and some of the motor complications of Parkinson's disease. But it is a surgery, and with it comes risks of infection, of hemorrhage, of stroke. Although in the hands of a good surgeon, those risks can be, minimized. It also requires a hospital stay. It requires that people go under general anesthesia. And after they get it placed, it is a process to get it to help. It can be a very good therapy for select candidates, but it requires continued follow-up with the neurologist for programming of their DBS over the years. Focused ultrasound is a newer therapy and it's been gaining a lot of great data and effectiveness. And it uses high intensity focused ultrasound waves to create a lesion in the brain under MRI guidance. Now, this is not a surgery, as Dr. Langevin will talk to you about, but it's a minimally invasive procedure. It involves no cutting. So with it, the risks here are much more much lessened. There's no anesthesia. It's a day procedure. And, after this procedure is done, most patients may not have to follow up with a neurologist. There's no programming or anything that a neurologist will need to do after this surgery. So it can be good for those patients who, maybe I have somebody who would be a good candidate for the DBS in terms of treatment, but they're not a great surgical candidate, or they just tell me, you know what, I just don't want the invasiveness of surgery. So, we'll talk about focused ultrasound. So we usually have a conversation about both. So who's suitable for this treatment? as I mentioned, somebody with a good diagnosis of essential tremor or Parkinson's. They have to be at least 22 years old for ET and 30 years old for Parkinson's. Tremor limits their daily activities, and they've tried at least two medications and either not able to tolerate them or they don't get enough relief. They're in the advanced stages of Parkinson's and they're having those motor complications. It is done under MRI guidance, and so people need to be able to lie flat in an MRI scanner and they need to be able to tolerate the procedure. So if somebody's very claustrophobic, unfortunately, Dr. Langevin, we wouldn't be giving you anesthesia through it. So we have to be, people have to be able to be awake and be able to communicate throughout the procedure. So in summary, essential tremor, very common condition. It is a tremor disorder with tremor that progresses over the years that affects daily activities and over time can impact somebody's quality of life. We have medical therapies that we use very often, but unfortunately in people with moderate to severe tremor, the efficacy of those medications at best we say is 50%, and some people are not even able to tolerate them. Parkinson's disease is a much less common condition, but over the years, tremor also can be bothersome for people, and the motor complications can also affect quality of life. So we have several neurosurgical techniques now that we have available to discuss with patients. So Dr. Langevin is going to take over. He'll put on some of the same information I'm just sharing with you here. So I would advise people at the end to take a picture if they don't have a pen handy. So if you're interested or need more information. I'm going to hand it over to Dr. Langevin now.
Great. Thank you, Dr. Diaz. And thanks everybody for attending the webinar tonight. Just going to present here our slides. Great. So my portion of the talk, I'm going to be stressing out more the focus ultrasound, like basically how does it work, how do we perform it, and then going over the risk and benefits of the focus ultrasound. And we are then going to leave a lot of time available for questions at the end. This slide shows that, focus ultrasound, although we hear about it more these past few years, it's been around for a number of years. So the company was founded in 1999, actually. And some of the first treatments were performed at the early 2000s. And so you see the progression, the initial FDA approval for a single site, more recently, the approval for the contralateral side or the second site, so that you can have tremor control now on both sides of the body, although you do need a period of 9 months between the two treatments. There should be like one more entry. So since just last year, Insightec has received now the approval for an additional target for Parkinson's disease, although it's not fully released. But it's something that's exciting that's coming in the future. So just to highlight the technology behind the therapy. So you can see on this slide that the treatment itself is performed in an MRI environment. So this is a regular MRI machine. The only thing that's different is the helmet portion that you see on the table. And so that's the portion that does deliver the ultrasonic waves to the intended target. The MRI obviously is connected to a series of computers that are controlling that ultrasound machine so that we can deliver the ultrasonic wave directly to the precise spots that requires a treatment. And then just running through this animation, essentially the ultrasonic waves are produced by this helmet, and they enter through several hundreds to a few thousand directions from all over the skull. And so the energy is like distributed very small through all the pathways, but it all concentrates into like one precise spot where it elevates the temperature to create the lesion of probably like 2-3 millimeters. The advantage of that treatment, as Dr. Diaz mentioned, is that you don't need anesthesia to perform the procedure since there's no surgery. So there's no incision that's done. There's very minimal discomfort or pain as a result of the procedure. So then we can avoid the recovery after the surgery for the pain, the incision, the scarring. There's also no device implanted, so as a comparison to deep brain stimulation, where a device is inserted to help treat the tremor. In the case of focused ultrasound, there's no device, which means that you don't need to have a device adjustment, going to your provider to get the stimulation adjusted to reach good tremor control. And there's less upkeep on the device either. So like in a case of DBS, the device requires replacement or it requires to be charged up by the patient. The effects of the ultrasound are typically instantaneous. So you can see some example here of patients who drew spirals. And actually, these are some example from our own practice, just from approximately a week ago, where you can see at baseline here on the left side with a fair amount of tremor. And then at the end of the treatment, when the patient leaves to go home, there's a slight tremor still present, but you can see how the lines are much more legible, and so is the signature as well. And this was a second patient where the initial tremor was not as profound, but still disabling to the patient. So especially eating in public, as well as using his hand for mouse control for his job. And so you can see at the end of the treatment here, he was very happy. You can see how like the spirals are a lot smoother and then the lines straighter for the drawing. This video shows a testimony for a patient from Inside Tech. I think it covers well some of the experiences that the patient can experience with the focused ultrasound. So we'll play it for a few minutes here.
I've always had essential tremors since I was a child. In a work setting, I need to write, I need to be able to sign contracts, I check into hotels, and the shakes hurt. I mean, it makes it very difficult for me to get through those parts of life. I found on the internet the procedure involving the focused ultrasound, and it was really compelling. I don't have to have a traditional brain surgery. The first thing I'd like to do after the treatment is to sign my name. It sounds really simple, but it's a wonderful thing for an individual who struggled to sign your name when you're trying to check into a hotel, rent a car, or do anything. So if I can sign my name without having my hand shake, that's going to be wonderful.
So some of the elements of the story are things that we hear quite often. So a lot of patients, hear about focused ultrasound through the internet, social media, occasionally physicians, but oftentimes kind of find it on their own, and we're left partially treated with medications, sometimes with still very disabling tremor. And the procedure offers like an option where you don't need to have surgery in order to have your tremor under control. So far, approximately 30,000 procedures have been performed, both for a combination of essential tremor as well as the tremor associated with Parkinson's disease. So you can see how for the graph here on the right-hand side, how like essentially it's an exponential increase in the number of treatments per year. So like the experience that we have acquired as clinician in our society is exponential as well. So like we have a lot more experience. For the targeting selection of the areas to treat for the tremor control to get better symptomatic control and also reduce the incidence of any complication or side effects from the procedure. Another question that was unclear at the very beginning of focused ultrasound is whether or not the effects of tremor control will be lasting over time. So we start now having clear answers to this question because the first patients were treated many years ago. And essentially, it's been published now across a number of journals, but the efficacy of the treatment is maintained over time. So the patients can still expect approximately 75% tremor control over time without any additional side effects long term after the treatment is done. A lot of patients will experience some degree of headaches, when they leave on the day after the procedure. That's related both to the placement of a frame where the pins are inserted, as well as the delivery of the ultrasonic waves themselves. So sometimes it could be a sensation of heat and some dull headache that is associated with that. Those symptoms are treatable with over-the-counter ibuprofen and Tylenol, and they dissipate after a few days. Other side effects that we have seen are numbness or tingling in the treated extremity, so like the arm where we're treating the tremor, and as well some imbalance when the patients are walking. And so these are side effects related to swelling around the area of the lesion inside the brain. So those regions are important for the sensation and the sense of position of the body in place, in space. And so as the swelling resolves, like those side effects also go away. But it's something to keep in mind that after the procedure, there could be some headache, and that you may have to be more careful when you're walking around to make sure that you're keeping your balance properly for the first few days. These are the graph from one of the seminal study that was published in one of the top scientific journals showing the effects of the focused ultrasound. So in the first graph on the top left, the disability is dropped here after the thalamotomy or after the focused ultrasound treatment. So you can see the blue bar. The red bar is a sham treatment where the patients were inside a scanner but did not receive the ultrasonic wave treatment. The improvement goes across multiple domains in patients' life. So, obviously eating, drinking. A lot of patients tell us that they stop going to restaurants with essential tremor because they feel self-conscious about the symptoms. So that's an immediate improvement. And simple things like getting dressed, writing, and improvement at their work. So it could be like controlling a mouse, for example. Similarly, another score of the tremor shows this similar improvement. And again, the improvement across like multiple domains, including psychosocial, because patients can then resume a lot of their hobbies and their social activities without feeling self-conscious about the tremor. A lot of our patients also resume their hobbies, so that requires a little bit more dexterity and fine motor control, like sewing or soldering. And this study shows how these results are maintained after multiple years. So this is a score of tremor at baseline, and you can see there's a significant drop after the treatment, and that drop is maintained across 5 years in this case. Similarly, on the graph here on the right-hand side. So these results are showing at least maintenance over 5 years. We know from clinical practice that extends at least 10 years just from the results of the first patients that were treated with focused ultrasound. So shifting gears now to treatment days. So what to expect on the day of the treatment. And so this video shows a little bit of animation, kind of muted here. But essentially, it's very similar to obtaining an MRI, right? So you can see a patient here entering the MR magnet. We are in the control room, selecting the target that we want treated. We deliver test dose to raise the temperature just a little bit to inactivate the area without completely lesioning. And then we test the patient. So this shows a button that is provided in case the patient was to experience nausea, or symptoms where they feel like they need the therapy to stop. So that's always an option. So these are the kind of calculations that we're doing with the help of the software to precisely deliver the energy to the intended target. And once that is done, then we test out with drawing spirals, signature, using a test cup to pretend drinking, and looking at the tremor control. Essentially, we look for two things. We look for improvement in the tremor, so ideally 50% or more, and we look for the absence of side effects. So we discuss the side effects of numbness, tingling, obviously, or weakness in the extremity. And so if we don't see any of those side effects, and then we see a substantial improvement in the tremor, then we proceed at the final treatment at that precise spot that we just tested. If we don't find enough tremor control, then we move slightly until in other words, we find a sweet spot, then we deliver the final dose. So just go over one more time. On the day of the procedure, our patients come through the outpatient imaging center of the hospital. So you're entering an area where you would go to obtain a scan, for example, if you were scheduled that day. Once the scanner is ready, then you're coming back towards the holding area of the MRI. And there we shave the head. So we have to shave all the hair because we cannot have any air gap between the ultrasonic machine and the skin. So it has to be perfectly tight, essentially in a space filled with water, which means that we have to shave all the hair. And then to prevent any motion of the head while the ultrasonic waves are being delivered, we secure the head inside a frame that involves a box basically around the head with 4 pins that are inserted, 2 in the front and 2 in the back under local anesthesia. Once the frame is placed, then you undergo the scanning. Those images are used to plan the procedure, so where we select the one spot that we want treated, and then we proceed with the test dose as well as the evaluation, so what we just discussed essentially. And once we're happy with the test dose that you receive, that your tremor is better controlled, then we proceed with the final treatment. Once the final treatment is applied, occasionally we apply a second dose slightly at a different target to help with the longevity of the treatment. So it lasts longer, many more years, as well as a slightly more profound tremor control. And once that is completed, then you come out of the MRI, we remove the frame, and you go home. So we discussed some of the benefits before, but just to go over it one time. So the absence of any implantable device, so especially beneficial for patients who would have more difficulties with technology, so managing recharging a device or coming to several appointments for adjustment with programming. Or would have difficulties with undergoing procedures for the replacement of the device, every 3 to 5 years, where we have to switch the new battery. In addition, patients who have high risk of infections may not be good candidates for DBS, and so, like in that case, the focused ultrasound may present an advantage. In addition, we've seen occasionally patients who are living a very active lifestyle who feel like the deep brain stimulation is sort of like in the way occasionally because of pulling in the neck for the wires, or sometimes the battery under the shoulder blade could interfere with some more strenuous physical activities like playing tennis, for example, or bowling, or patients who are using rifles. Sometimes so the device can get it in the way. So those are all situations where perhaps the focused ultrasound could be a preferable treatment over DBS. The absence of anesthesia is something that's the most relevant for patients who have cardiac and pulmonary issues, a lot of medical problems where the risk of surgery would be increased. So you can see as we discussed, basic stuff like returning to restaurants, without feeling self-aware of the tremor. Insurance coverage. So Medicare is covering for focused ultrasound, and most private insurers have follow as well. Occasionally, it requires us to explain the reasoning for selecting the therapy or to touch base with the insurance reviewers, but we haven't had any problems getting it covered. Second side, so that refers to the procedure that we discussed is performed on one side of the brain to treat the tremor on the other side of the body, which means that when you go home that day, the tremor is only controlled in one extremity, one side. However, you do have the option of undergoing a second treatment to treat the other side. And essentially is repeating the exact same procedure 9 months after the first one is performed. And the results are very similar on the other side, so about approximately 80%, so 75–80% tremor control. The side effect profile is very similar as well, so like difficulty with balance initially after the treatment, some numbness and tingling is possible. However, those side effects improve over time. Just to finish discussing the second site now for the treatment of Parkinson's disease. So it's possible currently to treat the tremor associated with Parkinson's disease with the same target that we have been discussing during the presentation. However, now the FDA has approved a second target for InsightTech that will focus on the treatment of rigidity. So for those patients who have Parkinson's disease, so there's a few data points now that are starting to be published, although the results are still preliminary. But here on the left-hand side, you can see the main outcome data that's used for Parkinson's disease, showing the severity of the condition. And in the yellow line is the total score of the test, but the blue line is like highlighting the motor aspect of Parkinson's disease. So that's like the slowness of movement and the rigidity, so like the stiffness associated with Parkinson's disease. And so you can see that those are the symptoms that are primarily improved with that target. So some investigators are looking at the option of doing dual targets, one targeting the tremor associated with Parkinson's disease, and using the second target to then address the problem with rigidity and slowness of movement to address the majority of the symptoms of Parkinson's disease. So in summary, we hope that the presentation has shown that focused ultrasound can reduce tremor and improve the quality of life for those patients suffering from essential tremor, as well as patients suffering from tremor-dominant Parkinson's disease. Some of the advantages that we discussed are that the effects are immediate, after focused ultrasound, without the need for implantable device or adjustment for programming session. There is no anesthesia involved. In fact, we need you fully awake during the procedure so that we can test out, the treatment before delivering the final dose. And there is no incision, so there's less risk of having infection, scarring problems, and less pain to recover from after the procedure is completed. So here is the contact information for our program. There is a phone line that's dedicated for referral to this specific program, as well as an email that's monitored by our staff in case you have questions or requests. So on that, we'll take any questions you have.
Yes, thank you so much, Dr. Diaz and Dr. Langevin, for that very informative information. Once again, please utilize this contact information that's on the screen. So if you want to write it down or snag a quick photo of it, please do so. And the team at Providence Little Company of Mary would be happy to answer any of the questions that you guys have. But again, please utilize that Q&A button that is located at the bottom of your screen. We already have a few questions in the chat, so I'm going to go ahead and just start right off with the first one. And that is, I take medication and they work okay, but I feel horrible when I'm on them. Can I get focused ultrasound and stop my medication?
I'll take that one. I mean, it depends on the diagnosis, right? So, I mentioned in my talk, we have various medications that are available for both, and it's not uncommon, both for Parkinson's and essential tremor. Sometimes these are not well tolerated medications, and working with your neurologist to see if there's a dose or a combination of medications or a different medication to see if before we over move on to something that is, whether it's DBS or focused ultrasound, is we always make sure that we've given everybody a good trial of medications. Having said that, if people do have very problematic symptoms, either tremor or Parkinson's symptoms, some of the complications in tremor of Parkinson's, and they've really given medications a good try, yes, that might be an indication to discuss focused ultrasound with your neurologist.
That was a great answer to that question. We see that question quite often. The next question that we have are side effects of focused ultrasound permanent, or will they go away with time?
Yes, fortunately, the majority of side effects will go away in time. The initial one of like headache is directly related to the procedure of placing the frame as well as delivering the ultrasound. This is probably the first thing to resolve after a day or two. Uh, some of the other side effects that relate to numbness, paresthesia, so that's pins and needles sensation, and the imbalance. So those side effects are related to swelling around the area that was a lesion inside the brain. So we deliver the ultrasonic waves. They focus on a small area of about 2-3 millimeters. But after all that energy is deposited to the tissue, there is a rim of swelling, just as the body responds to any type of injury. And then it can take several days to a few weeks for that swelling to resolve, at which point then your side effects would then improve and get better.
Great, thank you so much. The next question is, will this procedure help with Parkinson's disease patients with cognitive decline?
Yeah, unfortunately, there's no data that shows, at least that I'm aware of. We're treating specific areas of the brain, as Dr. Langevin showed, that have to do with movement, with tremor, with mobility in Parkinson's, with tremor in Parkinson's, and essential tremor. And unfortunately, those targets don't really play too much of a role in cognitive function. Now, cognitive changes can be part of both conditions. Actually, some people with essential tremor can have some mild cognitive changes. But unfortunately, these are not, I'm not aware of any data where cognitive improvement is relieved, or cognitive decline is relieved with focused ultrasound. Now, if people have cognitive impairment, unfortunately, sometimes they may not always be a good candidate for the surgical option. As I mentioned, deep brain stimulation can be a great therapy, but some people are not candidates because of cognitive decline, and we screen that out before we, refer somebody for DBS, for deep brain stimulation. Focused ultrasound, it's not a contraindication. So if people have cognitive decline and are not candidates, they may be candidates for focused ultrasound.
The next question is, I have a knee replacement. Am I still a candidate for focused ultrasound?
Uh, yes, so that relates to implantable devices, and contraindication to MRI. So the majority of devices now are MRI compatible that are on the market. And so it's really a case-by-case basis where we discuss with the radiologists and sometimes the implant manufacturers to confirm that a device would be compatible. But in the case of large joints such as knee or hip, so those are not contraindications, so it should be fine to proceed.
It looks like this patient is coming from out of town. How long should they expect to stay before and after the surgery?
It's a little bit of a personal choice. Technically, you could come in town essentially just for the day of the procedure and then fly back on the same day. Um, Most of our patients we prefer to see them 1 week after the procedure, at which point our protocol includes to repeat an MRI to evaluate for the lesion that was created and confirm that there is no side effect. And so it might be more prudent just to make sure that if there are any side effects, we can institute any treatment or have like a long-term plan. That said, if it doesn't fit in the schedule, it's possible to come in only at the day of treatment, and our office are able to, we're equipped with telehealth equipment so that we can follow patients remotely using video conferencing.
Great. The next question is, can we get copies of this lecture materials? And I can answer that question actually. So everyone will receive an email in about a day that will include a webinar recording. So you can go and watch this presentation again. It will also be posted on YouTube where you can access it that way. And then the next question we have is, I was recently diagnosed with essential tremor. What challenges should my family and I expect with the diagnosis?
So both of the conditions I talked about today are what we call long haul conditions. They span over decades, and
Mm-hmm.
they're also very individual, right? So again, when we talk about sort of the progression of these conditions, there can be a lot of variability. I have patients that have had essential tremor for years, and while their tremor bothers them, it still doesn't affect them, and they're still able to work, and they're still able to do all their daily functions, although they're annoyed by the tremor. And then there are other people, unfortunately, that over the years, and over the years, we talk about 5, 10, 15 years, where the tremor can get worse over time and can affect their ability to do tasks, like I mentioned. So I think the best that when we're having this conversation with clinic, I said it's always good to have a neurologist, if it's not a movement disorder neurologist, at least have a neurologist that you follow with regularly, making sure that you're not getting put on medications that are, making your tremor worse. Follow it over time. And if need be, start with these medications. But not everybody gets to the point where they need these surgical options. These are good for people that have very bothersome tremor and unfortunately haven't really responded to medications as well.
We have around 3 more questions in the chat, but the next one is, how long is the typical procedure? Is there any impact on other Parkinson's disease symptoms besides tremor? Example, fatigue, balance, rigidity, etc.
Yes, so the procedure itself is roughly 2 to 3 hours. That includes the time for prepping, shaving the hair, placing the frame, and frankly, the majority of the time is spent obtaining the scans. So as you know, MRIs take a long time to obtain, and so that's where most of the time is spent. The actual delivery of the ultrasound is only a few seconds, so it's very short. As it relates now to the second question for Parkinson's disease, there are essentially 2 targets. The classic target is the one that's used for essential tremor and for the tremor in Parkinson's disease. That target would be expected to only improve the tremor component in Parkinson. However, Insightec just received FDA approval for a second target. There is not as much, a lot less experience with that target as of yet, as we're still accumulating scientific evidence. But the experience so far is that that second target will indeed improve other symptoms of Parkinson's disease, including the rigidity and the slowness of movement. Probably not balance issues, so those are difficult to treat surgically, but it seems like it will improve and make the movements more fluid at least.
Yes, and this question is pretty similar to that last one, and it says FUS treats the symptoms of Parkinson's disease and essential tremor. How do you manage the underlying disease that may worsen post-focused ultrasound? So I don't know if you have anything left to add with that second question.
Yeah, I mean, it's important to know that unfortunately for both these conditions, we don't have anything at this time that's curative or that we could say stops the progression of these conditions. These are symptomatic therapies. The good thing is that we have symptomatic therapies for, good, both medical and surgical. We have good symptomatic therapies that control the symptoms. And so many times I think about focused ultrasound in the sense of, while it's not curative or protective, if somebody is, 5, 10 years into these conditions and they have disabling symptoms, it can really control the symptoms and put them back, a number of years where they're more functional and being able to do things. So that's the way that I see these therapies.
I think that was a great answer. The last question that we have that is currently in the chat. So if you have any more questions, please put them in the chat super quickly so we can get them answered. But it says, focused ultrasound for Parkinson's disease is covered under Medicare, correct? Question mark.
So yeah, the coverage currently with Medicare relates to that it's based on the target. So the target for tremor, both for essential tremor and the tremor of Parkinson's disease, is covered by Medicare. However, Medicare has not rendered an opinion regarding coverage for that second target that will look into rigidity and slowness of movement. So that we still have to wait for that approval. So the FDA has approved the target last year, but it takes time for CMS to review the data and then decide about approval and coverage on a Medicare side.
Correct. Thank you so much. Well, it looks like that was the last question that was in the chat. So I want to thank you both, Dr. Langevin and Dr. Diaz, for being here this evening. And I want to remind everyone to please take a photo or write down the information that's on the screen if you would like to reach out to the team. They'd be very happy to answer any questions that you guys have. So again, thank you so much for being here this afternoon. And we appreciate everyone joining us.
Thank you.
Awesome. I hope everyone has a good rest of your night. Thank you guys so much.
Thank you.